So let's see Shigella infections or the Shigellosis. Shigella, the most important agent of bacillary dysentery, is named after Japanese microbiologist Kiyoshi Shiga, who isolated the first member Shigellosis dysentery serotype 1, the Shiga bacillus, in 1896 from epidemic dysentery. Classification based on a combination of biochemical and serological characteristic O antigen, Shigella can be classified into four species: Shigella dysentery, Shigella flexneri, Shigella boydii, and Shigella soni. Based on O antigen, each species is further typed into several serotypes. Shigella dysentery has 15 serotypes, whereas Shigella flexneri and Shigella boydii have 8 and 19 serotypes respectively. Shigella soni is antigenically homogeneous and has only one serotype. However, it can be typed by colicin typing into 26 colicin types. Pathogenesis. Shigella is one of the most important cause of bacillary dysentery. Mode of transmission. Infection occurs by ingestion through contaminated fingers, most commonly food and water, or rarely flies. It can also be transmitted sexually in homosexuals. Minimum infective dose as low as 100 to 10 to 100 bacilli are capable of initiating the disease, probably because of their ability to survive in the gastric acidity. Entry via M cell. Bacilli and enter the mucosa via M cells and are then engulfed by macrophages. Subsequently, the macrophage release the bacilli, which induce the recruitment of inflammatory cells to the infected sites, releasing cytokines, which in turn can cause acute colitis, the hallmark of shigellosis. Invasion is determined by a large virulence plasmid, which codes for important virulence factors such as IPA proteins and type 3 secretion system. Direct cell-to-cell spread. Shigella can spread directly from one host cell to another by inducing actin polymerization of host cells mediated by ICSA proteins. Exotoxin. Some serotypes of Shigella also produce enterotoxins. Shigella enterotoxin SHET. It is structurally similar to cholera toxin and is found essentially in Shigella flexneri 2A. Shiga toxin. It is a cytotoxin produced by Shigella dysentery type 1. It is structurally and functionally similar to verocytotoxin of EHEC. It inhibits protein synthesis by inhibiting 60S ribosome. It enhances local vascular damage of intestine as well as internal organs such as kidney and brain. Endotoxin acts similar to any other gram-negative endotoxin and induce intestinal inflammation and ulcerations. Clinical manifestation. Shigellosis typically evolves through 5 phases. Incubation period. It usually lasts for 1 to 4 days. Initial phase is characterized by watery diarrhea with fever, malaise, anorexia, and vomiting. Phase of dysentery. It is characterized by frequent passage of bloody mucoplurulent stools with increased tenesmus and abdominal cramps. Endoscopy shows an edematous and hemorrhagic mucosa with ulcerations and overlying exudates. Most of the cases are self-limiting. Phase of complication is commonly seen with children less than 5 years of age. Intestinal complications such as toxic megacolon, perforation, and rectal prolapse. Metabolic complications such as hypoglycemia, hyponatremia, and dehydration. Ikari syndrome or toxic encephalopathy is a metabolic complication of shigellosis, manifest as altered consciousness, seizure, delirium, abnormal posturing, and cerebral edema. Bacteremia is rare and can lead to meningitis and pneumonia. Rarely cases of vaginitis and keratoconjunctivitis have been reported. Post-infectious phase, patients expressing HLA-B27 develop an autoimmune reaction months after shigellosis, characterized by reactive arthritis, ocular inflammation, and urethritis. It is seen only after Shigella flexneri infection occurs in 3% of the cases. Epidemiology. Risk factor for shigellosis include overcrowding, poor hygiene, and children less than 5 years. It tends to occur as epidemics in developing countries such as Indian subcontinent and sub-Saharan Africa. Shigella flexneri accounts for maximum number of cases, 60% in the developing countries including India, whereas Shigella soni is more prevalent in developed and industrialized world, accounting for 77% of the cases. Cases caused by Shigella dysentery type 1 are associated with high mortality. It usually causes epidemics of dysentery, particularly in refugee camps. Humans are the natural host and cases are the only source of infection. Chronic carriage is rare except in malnourished children or AIDS patients. World. Shigellosis is the most communicable disease among the bacterial cause of diarrhea. Worldwide, 163.2 million cases of bacillary dysentery with 5 to 11 lakh deaths occur annually, of which majority are from developing countries. Children less than 5 years account for nearly 69% of the cases. With improved sanitation, the incidence of shigellosis is decreasing. However, the worrisome part of the present day is the development of drug resistance among the Shigella strains. Lab diagnosis. Fresh stool is the ideal specimen. Rectal swabs are not satisfactory. A specimen should be transported immediately or sent in transport media such as sacks, buffered, glycerol, saline. Wet mount preparation of feces shows large number of pus cells, erythrocyte and macrophages. Culture to inhibit the commensal fecal specimen is inoculated simultaneously into enrichment broth and selective media. Enrichment broth such as saline F broth, tetrathionate broth and gram-negative broth are used. Selective media such as mildly selective media. On McConkey agar, the growth appears as translucent and non-lactose fermenting pale colonies. Highly selective medium contains higher concentration of bile salts as inhibitory agent. Examples include DCA, deoxycholate citrate agar, producing colorless NLF colonies, and XLD agar, xylose lysine deoxycholate, producing red colonies without black center. Culture smear and motility testing. Gram stain smear of colonies reveal short gram-negative bacilli. They are non-motile, non-capsulated, and non-sporing. Identification of Shigella from colonies is made either by automated infection systems such as Vitek or by conventional biochemical test as described below. Shigella is catalase positive except Shigella dysentery serotype 1 and oxidase negative. ICUT test, indole test negative, citrate test negative, urease test negative, and TSI triple sugar iron test shows alkaline or acid. Gas absent, H2S absent. All Shigella species are mannitol fermenters except for Shigella dysentery. Automated method Malditov poorly differentiates Shigella from E. coli as they share same ribosomal proteins. Serotyping because of biochemical variation, identification of Shigella is always confirmed by slide agglutination with polyvalent antisera genus specific. Then the species identification can be done by using group specific antisera specific for serogroups. Serotypes under each species are further detected by using type specific antisera. Colicin typing can be done for S. soni. Antimicrobial susceptibility testing is done on Muller-Hinton agar by disc diffusion test. Treatment. Shigellosis because of the prompt transmissibility. Current recommendation is that every case of shigellosis should be treated with antibiotics. Ciprofloxacin is the drug of choice. Alternative drugs which are effective are ceftriaxone, azithromycin, pivmelicinam, and some fifth generation quinolones. Duration of treatment is about 3 days except for shigellosis dysentery type 1 infection 5 days. Infections in immunocompromised patients 7 to 10 days. Oral dehydration solution ORS should be started for correction of the dehydration, and nutrition should be started as soon as possible after the completion of initial rehydration. Prevention. Being highly infectious, strict infection control measures of contact precaution should be followed. Hand washing after handling of children's feces and before handling of food is highly recommended. Stool decontamination example with sodium hypochlorite has been proven useful. No vaccine against shigellosis is currently available, though several clinical trials are being conducted. Edwardsiella infection. Edwardsiella is a commensal in the gut of reptiles and fishes. Human infection is rare, associated with ingestion of inadequately cooked aquatic animals or due to snake-related injury. E. tarda is the most frequently associated isolated species of Edwardsiella in clinical specimens. It is associated with gastroenteritis, most common presentation, followed by extraintestinal manifestation such as septic shock, liver abscess, and infections related to trauma in aquatic environment. Identification is made either by automated identification systems such as Malditov or Vitek or by conventional biochemical test. Fermenters, fewer sugars, only glucose and maltose. Non-lactose fermenters reduce H2S. Treatment. Unlike E. coli, E. tarda is usually susceptible to most antimicrobials used for gram-negative bacilli such as quinolones and cephalosporins. Now comes the Salmonella infection, salmonellosis. Salmonella are antigenically complex, comprised of 6 species which in turn comprise of several serotypes based on their surface antigens. The human serotypes belong to Salmonella enterica, subspecies enterica, which can be further divided into 2 clinical groups: typhoidal salmonella and non-typhoidal salmonella. Typhoidal salmonella include serotype S. typhi and S. paratyphi A, B, and C. They are restricted to human hosts in whom they can cause enteric fever, typhoid or paratyphoid fever, characterized principally by bacteremia and multi-system involvement, and therefore are discussed under bloodstream infections. Non-typhoidal salmonella or NTS, the remaining serotypes can colonize the intestine of a broad range of animals including mammals, reptiles, birds, and insects. They can also infect humans, causing foodborne gastroenteritis and occasionally septicemia. Non-typhoidal salmonella include the pathogenic salmonella other than S. typhi and S. paratyphi A, B, and C. Majority of infection due to NTS are caused by S. typhimurium and S. enteritis, followed by S. Newport, S. javiana, S. Hedlenburg, and S. cholera suis, and S. Dublin. Non-typhoidal salmonella versus typhoidal salmonella. Non-typhoidal salmonella differ from typhoidal salmonella in many respects. Zoonotic NTS can be acquired from multiple animal reservoirs, whereas the typhoidal salmonella has strictly human pathogens. Transmission of NTS is most commonly associated with animal food products, especially eggs, poultry, undercooked, ground meat, and dairy products. Typhoidal salmonella are mainly waterborne. Resistance compared to other enteric gram-negative pathogens, Salmonella are relatively resistant to many environmental factors such as drying, salting, smoking, and freezing. This explains why they survive in diverse range of foods. Seasonality. Transmission of NTS is highest during the rainy season in tropical climates and during the warmer months in temperate climates, coinciding with a peak in foodborne outbreaks. Prevalence NTS are widely prevalent in developed as well as developing countries. Typhoidal salmonella are mainly confined to developing countries. Worldwide, NTS causes more than 90 million enteric infections and 1.5 lakh deaths annually. Outbreaks of NTS are common in hospital. Typhoidal salmonella outbreaks are community based. Pathogenesis is similar to that of enteric fever except that NTS gastroenteritis there is massive neutrophil infiltration into intestinal mucosa in contrast to enteric fever where there is mononuclear cell infiltration. Clinical manifestation. Gastroenteritis infection with NTS often results in gastroenteritis characterized by nausea, vomiting, watery diarrhea, fever, and onset of abdominal cramps. 6 to 48 hours after the ingestion of contaminated food, gastroenteritis is uncommon in typhoidal salmonella. Gastroenteritis caused by NTS is usually self-limited. Diarrhea resolves within 3 to 7 days. Patients excrete the organism in stool for up to 4 to 5 weeks after infection. Less than 1% of the case become chronic carriers and excrete bacilli for more than 1 year. Bacteremia. Up to 8% of the patients with NTS gastroenteritis develop into bacteremia, which leads to either endovascular infection or seedling to various organs, leading to metastatic localized infection. Risk factor for bacteremia include NTS serotype most common during being the S. cholerae source pig and S. dublin source cattle. Age infants and elderly people are at higher risk. HIV and other conditions with low immunity. Endovascular infections such as endocarditis and arthritis occur rarely in people with pre-existing valvular heart disease. Metastatic localized infections such as intra-abdominal infections such as hepatic or splenic abscesses or cholestasis. NTS meningitis common in adults with HIV infection and infants. Pulmonary infections such as lobar pneumonia and lung abscess. UTI, pyelonephritis and cystitis in people with underlying renal stone or urinary tract abnormality. Genital tract infection include ovarian testicular abscess, prostatitis and epididymitis. Salmonella osteomyelitis is commonly associated with sickle cell disease, pre-existing bone disease, or hemoglobinopathies. Reactive arthritis Ritter syndrome seen in persons with SLA-B27 histocompatibility antigen. Treatment non-typhoidal salmonellosis in contrast to enteric fever where antibiotics are started as early as possible in uncomplicated NTS gastroenteritis. The treatment is conservative with fluid replacement. Antibiotic use is associated with increased rate of carriers and relapse, hence it is limited only to invasive NTS infection or severe gastroenteritis having higher risk of developing an invasive infection. Drugs given are similar to that of enteric fever in treatment. Ciprofloxacin is given for preemptive treatment for severe gastroenteritis. Ceftriaxone is indicated for bacteremia and invasive infections. Drug resistance NTS are more drug resistant than typhoidal salmonella. MDR strains of NTS are resistant to more than 5 drugs: ampicillin, chloramphenicol, streptomycin, sulfonamides, and tetracycline, abbreviated as ACSSUT. Increased use of ceftriaxone and ciprofloxacin to treat MDR strains leads to emergence of resistance to ceftriaxone due to production of AMP-C beta-lactamases and ciprofloxacin due to point mutation of DNA gyrase genes. Next come the Yersinia infections. The tribe Yersiniaceae comprise of genus Yersinia, which contains three well-established human pathogens. Yersinia pestis was isolated first time by Alexander Yersin in 1894 in Hong Kong. It is the agent of plague of fulminant systemic zoonosis transmitted from rodents by arthropod vector, the rat flea. It is discussed in later chapter. Yersinia pseudotuberculosis and Yersinia enterocolitica both cause yersiniosis. Yersiniosis is a zoonotic infection caused by enteropathogenic Yersinia species, that is Yersinia enterocolitica and Yersinia pseudotuberculosis. Pigs and other wild and domestic animals are the usual host. Human infection occur due to the consumption of contaminated food such as raw pork, milk, etc. It is most common in childhood and in colder climates. Patient present with abdominal pain and sometimes with diarrhea. Geographical distribution: Yersinia enterocolitica is found worldwide, most commonly in northern Europe and America. Outbreaks of Yersinia pseudotuberculosis are generally rare, have been reported from Finland. Serogrouping: Yersinia enterocolitica is further characterized biochemically 6 biotypes and antigenetically 60 serotypes based on somatic O antigen. Worldwide, most clinical infections are associated with serogroups O3 and O9. Yersinia pseudotuberculosis can be further differentiated into 6 serotypes 1 to 6 based on somatic O and flagellar H antigens. Clinical manifestations: overall, Yersinia enterocolitica is more frequently reported than Yersinia pseudotuberculosis. Self-limiting gastroenteritis, diarrhea with or without blood occurs in younger children. Intestinal complications occur in older children characterized by terminal ileitis, mostly Yersinia enterocolitica, and mesenteric adenitis. Patients present with acute pain abdomen may mimic pseudoappendicitis. Septicemia is seen typically in adults characterized with fever and leukocytosis. It usually occurs in patients with coexisting diabetes mellitus, liver disease, and iron overload. Post-infective phenomena in adults occurs commonly with Yersinia enterocolitica. It occurs as a result of autoimmune activity initiated by diversion of bacterial non-viable components in joints and other sites. Manifestations include reactive arthritis, mostly associated in person positive for HLA-B27. Erythema nodosum, it occurs independently without any link to HLA-B27 phenotype. Graves' disease: Yersinia enterocolitica contains an antigen similar to thyroid-stimulating hormone TSH binding site. However, whether this cross-reactivity has any significant role in Graves' disease remains unclear. Superantigen: some of the strains of Yersinia pseudotuberculosis express a superantigen mitogen, which has caused scarlet-like fever in Russia, similar illness in Japan, Izumi fever, and has been linked to pathogenesis of idiopathic acute systemic vasculitis of childhood called Kawasaki's disease. Lab diagnosis: culture isolation. For isolation from blood culture bottles, BHI broth should be used. For isolation from lymph nodes, aspirate culture is done by on conventional media, blood agar, nutrient agar, and McConkey agar. Blood agar, they produce granular translucent colonies with a beaten copper surface, non-hemolytic colonies. McConkey agar, growth of Yersinia pseudotuberculosis is poor. Yersinia enterocolitica grows well and produces lactose non-fermenting pale colonies. For isolation from feces, food, or soil, selective media should be used such as deoxycholate citrate agar, McConkey agar. Now coming on to Yersinia CIN agar, cefsulodin, irgacin, novobiocin. Typical dark red bull's eye appearing colonies are formed in 24 hours. Incubation plate should be incubated at 25 degrees Celsius and 37 degrees Celsius to differentiate from most of the other pathogens which grow only at 37 degrees Celsius. Cold enrichment can also be done by incubating in phosphate buffered saline at 4 degrees Celsius for 3 weeks. Identification: Yersinia enterocolitica and Yersinia pseudotuberculosis show the following properties by which they can be differentiated from Yersinia pestis. Differential motility: they are motile at 22 degrees Celsius but not at 37 degrees Celsius. Cold enrichment: growth improves on refrigeration 4 degrees Celsius. Automated identification systems such as Malditoff can also be used for accurate species identification. Serology. Antibodies can be detected by agglutination or ELISA using serotype specific O antigen types. In Yersinia pseudotuberculosis infection, antibodies appear early during the acute phase of illness, whereas Yersinia enterocolitica specific agglutinating antibodies are more likely to be found in convalescent sera. Treatment. Most cases of diarrhea are self-limiting. Treatment is required only for systemic infections, such as in case of septicemia. Fluoroquinolone, ciprofloxacin, or third-generation cephalosporins, cefotaxime are effective. Yersinia enterocolitica strains nearly always produce beta-lactamases, but not Yersinia pseudotuberculosis strains. Now comes the Plesiomonas. Plesiomonas is an oxidase positive motile fermenting gram negative bacillus recently has been included in the family Enterobacteriaceae based on DNA hybridization studies previously classified under Vibrionaceae family. Plesiomonas shigelloides is the only species it's so named because it is antigenically related to Shigella soni. It is found as saprophyte in water and soil and also as commensal in animal and rarely in human intestine. Human infection is rare and cause gastroenteritis, which may be severe in immunocompromised patients. Extraintestinal manifestation include rare cases of meningitis, septicemia, cellulitis, and septic arthritis. Infections due to non-GI pathogens. The following are the members of Enterobacteriaceae family, which mainly cause extraintestinal manifestation and therefore discussed in the respective systems. Uropathogenic E. coli UPEC accounts for most of the common UTIs. Typhoidal salmonella include the serotype S. typhi, S. paratyphi A, B, and C. They cause enteric fever discussed under bloodstream infections. Klebsiella species usually found as commensals in human intestine and as saprophytes in soil. There are three main species: Klebsiella pneumoniae, Klebsiella oxytoca, and Klebsiella granulomatis. Klebsiella pneumoniae further comprises of three subspecies. Klebsiella pneumoniae subspecies pneumoniae is the most pathogenic among all. It is responsible for severe lobar pneumonia, UTI, and pyogenic infections. Some strains can rarely cause diarrhea and have been shown to produce E. coli-like heat-stable enterotoxin. Klebsiella pneumoniae subspecies Ozini and rhinoscleromatis are the pathogens of nasal cavity and have been discussed in chapters later. The infection produced by Klebsiella oxytoca is similar to that of Klebsiella pneumoniae subspecies pneumoniae. Klebsiella granulomatis is the causative agent of sexually transmitted infection called granuloma inguinale or donovanosis. Now comes the Citrobacter species. They are the mostly environmental contaminants, occasionally cause urinary tract, gallbladder, and middle ear infection and neonatal meningitis. Serratia species, Serratia marcescens, is the medically important species found as saprophyte in the environment. However, it is being increasingly reported in various nosocomial infections such as meningitis, endocarditis, septicemia, urinary, respiratory, and wound infections. Triproti comprises of three genera: Proteus, Morganella, and Providencia. They are part of commensal in human intestine. However, they can cause nosocomial outbreaks of UTI, wound infections, etc. Morganella morgani is the commensal in sea fish, can cause food poisoning following seafood intake called scombroid food poisoning. Yersinia pestis is the causative agent of plague, a fulminant systemic zoonosis transmitted from rodents by arthropod vector, the rat flea. Okay. Now coming on to question, the assay on diarrheogenic E. coli, we can write short note on non-typhoidal salmonella and pathogenesis of shigellosis can also be done. Now coming on to MCQs, traveler's diarrhea is caused by ETEC. Culture media used for EHEC 0157H7 is sorbitol McConkey media. Which of the following Shigella species is mannitol non-fermenter? It's Shigella dysentery. A 20-year-old man presented with hemorrhagic colitis. The stool sample grew Escherichia coli in pure culture. The following serotype of E. coli is likely to be the causative agent. It's O157H7. Okay, the most common cause of infantile diarrhea in developing country is EPEC. All catalase positive except Flynn is catalase positive, Boyd is positive, Sony is positive. Which is not positive? Shigella dysentery type 1. And in tropical countries, India, bacillary dysentery is caused by Shigella flexneri. Okay, so this completes our chapter. Now next we'll be starting with cholera. Okay, like, share, subscribe. Thanks for watching.